Good day, everybody. I'm Dr. Robbie Wyatt, Chief Clinical Officer for Ergo-Flex Technologies, home of the Neon Trac, and this is our live patient demo Neon Trac webinar. I want to show you all something, just exactly how to set a patient up and why the clinical judgment of why I'm doing what I'm doing for any particular patient. So today, Andy is with us. Andy's 18. He was playing soccer last night. And he's an avid soccer player pretty much every day, right? Yeah. So he was pushing hard and he was decelerating, right? He got bumped and the right knee suddenly gave out on him, right? And he basically couldn't put any pressure on it after that. He came in this morning, I did an evaluation. He's got mild to moderate swelling around the knee, point tenderness in the posterior joint capsule, the posterior joint capsule, the lateral anterior joint capsule, in the insertion of the quad, and also insertion of both heads of the biceps femoris, so the hamstrings. He can go into full extension. It's very painful, and he can only do about 90 degrees of flexion. Past that, there's no gross ligament laxity. There is exquisite tenderness when I challenge the lateral collateral and the medial collateral. Anterior drawer seems to be okay. Posterior drawer seems to be okay. So there's nothing that's screaming that we've got a really bad tear. And it's not like we're looking for a specific, not like we're looking at a specific meniscal tear. It's really early to tell because it does have quite a bit of swelling. So what we did, I put him on the Neon Trac. I did protocol 4, which is gradient traction, so it basically takes it out. Now, since he is a high impact athlete, I put him at 17 pounds. Even though he's pretty slender, he's well under 150 pounds most likely, I used 17 pounds because he is a high impact. Protocol 4, because I want a nice gentle stretch. I want to milk that joint so that we can get some of the pressure out of it. So before we actually did that, how was your pain level this morning?
Like a 4.
Like a 4. What happened when we got you off?
Like a 1.
Like a 1, okay. So we did that with, I used the multi-radiance laser with that. And he got up and he felt better immediately. So my prescription for him is that we do that protocol 2 times a day for the next week. All right, that we're here. So he's got inside connections here. Kevin, who is the guy that puts all of our equipment together, specifically the Neon Tracs and the back on Tracs. And he called me last night and said, hey, can you help us out with this? Sure. But I needed to evaluate him and figure out, hey, do we need to do imaging first? Right now, imaging is, if I had access to an x-ray, I would shoot one without thinking twice. But right now, I don't have any absolute evidence that we have to have an x-ray. If I were in clinic, I'd have an x-ray, okay? Why didn't I go ahead and shoot an MRI? Very good possibility that if we shoot an MRI right now with all the swelling that's happening, it's not going to show us anything that's really torn because ligaments don't show up really well, especially mild to moderate grade 1, grade 2 sprain strains. And if it's swollen, you may not see any type of meniscal tear in there anyway because of the increased pressure. So we're going to see where he's going. He's using crutches, so he's not weight bearing. I want him to continue that for the next week. And then we're going to do this protocol that we're going through right now 2 times a day. I want him to do it morning and afternoon, at least Monday through Friday. If we can get him up here Saturday and Sunday, we'll do that as well. Okay? So I got him sitting. He's properly placed. We're going to use the thigh strap. Now for him, Andy was really, really tender when I was putting him on there. I want toe straight up. All right. Now, if you've seen this, this is drawer liner material, okay? It's about a 3-inch by 12-inch. Stuff you put in drawers or in the shelf to keep things from slipping around. If you do this, you slide it in. Now, he's got a very slender leg, okay? So our entrapment point is the calf. If you've got somebody like this, lift your leg just a little. Good. This material makes all the difference in the world. You don't have to overinflate the bladder. This comes in just like this. And have you scoop that just like that. We want the top edge here just at the inferior pole of the patella. We just want tight. It doesn't have to be super tight. Close this all the way. Good. So 6 to 8 pumps is all you're really going to need. All right. I've already got him set up for protocol 4, 17 pounds for 6 minutes. We'll go ahead and hit. He is ready to go. Now with this, in comparison to this morning, you've got less swelling. So I'm going to use cold laser right on top of this. They're class 4. I'm going to use our acute to moderate swelling. So it's just that simple. All you got to do is sit down, and here we go. How did it feel this morning when you first started?
Kind of stretching me out.
Okay. Was it painful while you were on it?
No.
Okay. That's very common. Patients typically, they may feel that their foot's going to sleep, like you said earlier, right? It's like my leg feels like it's going to sleep. But what happened when I took the strap off the first time?
Felt really good.
Felt really good right away. Almost always is very good. So in acute injuries, it's one of the big question marks. Something, a chronic problem, your evaluation, you're most likely 99% of the time you're going to be able to use this technology. Okay. An acute injury, you need to make sure that you don't have significant joint laxity. You want to make sure you don't have a locking joint. You want to make sure everything's working well and no absolute signs of a torn meniscus, complex or simple, or we just have an ACL, PCL, or lateral collateral that's just completely flunking away. Okay, because that's no fun. We don't want to be opening up and working on that. Right now, he's got mild to moderate swelling. We'll milk that joint because the first thing that happened for him was he lost full extension. I could drive him into full extension in that knee. Okay, he didn't like it. He didn't like it at all. All right, so I put him into full extension, and he comes up off the table on me. And then he's only at 90 degrees when we finished. Excuse me, before we started. Check your. I didn't check his range of motion afterwards. So that's one of the critical factors. Okay, so no gross laxity in the ligaments. Okay, and we don't want to be taking pressure off of the meniscus and floating an edge on one of those tears if he has a tear. Okay. But the big factor is we got to reset that full extension mechanism. When we set that full extension mechanism, everything starts to play much better. You might have any specific questions. We got about 2 minutes left on this protocol. Make sure you type them. Type. How many people we got with us today?
We have 8.
8.
We've got Dr. Simmons,
Dr. Petrie,
Dr. Petrie.
Dr. Benton, Kurt Simmons. Awesome. Great. Anybody have any questions? We're about to get into tough stuff here pretty soon. Anybody have any great testimonials? That'd be great as well if you let us know. So the other protocols I like, protocol 4 and or 5 for is a total knee replacement. Okay, acute injury. Typically protocols 4 and 5, and I'll use protocol 1 in acute if necessary. But for total knee replacements, I like protocol 4 and or 5. 99% of the time we use protocol 3. Protocol 3 is excellent for being able to get mild to moderate or even moderate to severe degenerative joints to open back up over the long term. So other therapies that we could use in conjunction with this, you could use the anodyne system. Rebuilder's got a great set of straps that you can put on and do this. I know Dr. Petrie used either the anodyne or the rebuilder. I think it's the rebuilder is what we talked about. Of course, you can use laser. You could use heat, ice. You could even use vibration if you wanted to use vibration very gently, say with a percussor. Break those up. Doing okay? All right. Grab some water. All right, so when we get done with this, we're going to do just a post-pain scale for him, figure out where we're at. And then I want to see where he's at with his knee flexion. The quality is great. Good. All right. Any questions, guys? Hit me up with some questions. Happy to answer. So, one of the other things that we have been getting pretty regularly is the bladder. Okay. The way this system actually works, it uses a cuff, blood pressure cuff, to inflate. That's why you don't have to have it super tight. That's actually what makes a big difference, okay? The key to this is that when you're done, you counterclockwise twist this and let all the air out. You're actually gonna give it a little squeeze. Laser's done, we're just about done here, and we'll give about 30 seconds. If you don't do that, what happens is air remains in the bladder, okay? And so what I did for him, I did 8 pumps, right? Because he's got a little smaller leg. I got 8 pumps, I got the drawer liner in there, and that whole snake. If you don't release that pressure in there, and remember this is a metered release, it won't release unless you ask it to release. The next time you pump it up, now we don't have 8 pumps in it, now we're putting 16 or 20 pumps. If you don't release that properly, the next time you may blow that bladder out, okay? So really, really important. When that happens, immediately open all the way, give a gentle squeeze. And Andy goes, oh. Perfect. Okay. So, just swing your leg around here for me. I want to do something. Like that. So, one of the things I want to do, now we got full extension. He's still got quite a bit. He's still anxious. But when I did that before this morning, he like flew off the table on me, right? Okay? Now, let's fit it. So we're still right there. So he's got something going on, okay? But when I can restore complete extension, much, much better. Okay? Go ahead and stand up. Let me know how that feels. So I did a pre-test on him, and when he put pressure on it like that, even with this, he was about a 4, correct? What's it feel like right now? Say again?
It don't hurt at all.
Doesn't hurt at all. That's what we should see when they're coming off. You reset that extension mechanism, pump that joint, everything's good. Thank you, sir. Be careful. And now, some of the specific things I told him on that cue is I don't want him wearing a shoe right now. I don't want him planting and not picking up. Okay. If he does that, that's how you can actually create a rotary component. That's how you tear some of the meniscus, the whole other set. So real easy things to do. At this point, make sure you don't have any pressure in it. Simply do this. She's ready to go for the next patient. Okay. So I want no pressure. So he needs to wear a sock. I want him to use crutches for the next week. All right. I don't want him putting a whole lot of pressure on. I want him testing it, but certainly not. Especially when he is sleeping. I make sure you're going to have a lot of covers or heavy blankets on there so that he rolls. All right. If you have any questions, let me know. We're going to switch cameras. We're going to go into some of the anatomy and why this actually works. Okay. So I've got my Da Vinci art here. This is going to be our normal knee. This is going to be our abnormal knee. This is actually how I'm going to draw out the meniscus. Okay, so show you here. The meniscus sits like this in the joint. That's why you have this. Okay, so we should have in these facets down here. The condyle drops down into the facet. Specifically in here, there is cartilage. Okay, this entire piece here goes from fibrous material to more cartilage as we go in because of the way, from cartilage material to more fibers. And I'll show you why that happens, okay? And then here, it's actually the top, this right here, in pink, or purple, whatever it's going to be, there's actually cartilage that sits in there, okay? And that's right here. So cartilage should sit here, up in here, here, down, right here, again in that little fossa, and over here. It also sits on the undersurface of the femur. This is a right knee. We're looking from anterior to posterior. That's the femur, okay? So that's how those systems actually work. Now, when we start taking a look at how the ligament system works, we've got the anterior cruciate ligament. I lost it for a second. It attaches anteriorly, lateral to medial. Okay. You have posterior, which is medial to lateral. Creates the X, that's why it's called a cruciate ligament. You have the medial collateral. You have the lateral collateral. Lateral collateral goes down and attaches to the femur, to the fibula. I can't get my words right today. Then the joint capsule goes from here all the way across. All right. Now, what are the structures that are actually in place that actually create synovial fluid? What's a key of them? Okay. So what are the structures in the knee that actually create synovial fluid? Because what we did with Andy was actually pump that joint. All right. That's why it's so effective on acute injuries. We're pumping the joint. It's swelling. It's trying to increase the joint space. Okay. We need to pump that joint because, as we all know, there's no direct blood supply, either arterial or venous, into or out of the knee. Right? How's that possible? Well, the joint capsule's sealed. So, the structures that create synovial fluid are our synovial fluid creators is cartilage. Right? Now, the meniscus, like 80% of it's cartilage. All right? So we got cartilage on the femur, on the tibia, and then also in the in the meniscus. So we got meniscus. What else we got? We have the synovial lining of the joint capsule. All right. Now I want you to think about this. The joint capsule itself. Okay. When somebody has a total knee replacement, what's creating synovial fluid then? Total knee replacements swell. They have blood-thin fluid in them. They still swell. So what's creating synovial fluid at that point in time? All right. So think about that. All right, because they wipe out this structure and this structure. Everything in here is gone. So all the cartilage, everything's gone. The blood supply for this cartilage comes from the femur. From this cartilage comes from the tibia. Right? So those are key factors. That's essentially what happens, right? So blood supply to the cartilage comes from mainly the bone marrow, but there's also another structure in there. All right? So on the posterior side, there is a genicular artery, just like that. Okay? So this is anterior, this is posterior. So that artery sits just like this, just posterior to the knee. All right? Then it has an arcuate artery that comes all the way around. The arcuate artery is what invaginates into the meniscus. All right? And that's what feeds, that's the blood supply to the meniscus. The meniscus is actually outside of the joint capsule, guys. It's outside. Okay, it's not inside, it's outside. It's considered outside the joint capsule. So when you look at the arcuate artery as it comes around, it sends blood supply in like this. Okay? So for the first third of that, everything that's happening in here, inside, this is cartilage. So this side of the meniscus is cartilage. Y'all remember this from school? This is fibrous. So as you get in closer in here, this is more a fibrous material because it's got less blood supply. okay? That's why inside here, inside that facet is so important for that cartilage to be in good shape, okay? Now, what happens in a Baker cyst? Baker cyst is a posterior exvagination of the joint capsule. So this joint capsule here, with the right color, pushes back and wipes out the blood supply. It actually pushes back on. Well, what happens if you wipe out this entire blood supply, or most of 90% of the blood supply to this meniscus? You think you may have a tear? Like with young Andy, who's pounded on it. He loves playing soccer every day. Maybe he knocks out the blood supply because of overcompression, repetitive injury. I always wondered, why can we have a perfectly healthy meniscus and then the next day, no joint space loss, and we got a tear? You know, we got a bucket handle tear, or we got a complex tear that comes all the way in like that. Which hasn't been a really good explanation, right? Well, really, I think it comes down to what's happening in the blood supply. You lose the blood supply, unless somebody gets roll blocked or something like that, and they just get they get along those. Now, let's talk about what's actually happening in a moderate to severely degenerative joint, right? Let's see if I've got everything I need here. All right, so we've got loss of joint space, right? Usually medial is much worse than lateral, typically. A lot of times, and this is where you see really nasty tears in the meniscus, what should be happening is, that should be actually, so because it's wearing like that, we have very little cartilage that's left. This cartilage is spotty, right? This one may be a little better, but it's spotty. Now the joint capsule is still in place, right? That really doesn't affect this. That means that we're still able to produce synovial fluid. Matter of fact, you still have blood supply here to the cartilage. If you've got blood supply, that means you can regenerate that joint, right? But this one's probably not that great. It's probably been wiped out, yeah? So what happens? What happens to the ligaments, all right? Because that joint space has been smashed down, that ACL is no longer taut and tight. PCL is no longer taut and tight, right? It folds over. The medial and lateral collateral are now folded over, okay? So when you look at Andy, Andy doesn't have those issues, right? He may, if we don't fix what he's got going on, he may overstretch, okay? Yep, Dr. Vinton, we can send one to you, that's not a problem. We can actually, so if he overstretches, so let's say he overstretched his lateral collateral. Okay, what's going to happen? He's going to try to actually, the body's going to try to tighten that back up. The problem is he's putting a bunch of pressure inside that joint. Excuse me, so inside he's got significant joint space loss. We have folding in the medial and lateral and PCL and PCL. Well, what happens to the ligaments that stay folded for too long? You get a ligament and it folds over. It starts, because it wants to stabilize that joint, because as that joint gets closer together, it starts doing lateral movements, right? Okay, so when it gets like this, now it starts interstitial scarring. It gets stuck in there, right? Well, now that's the problem. So these now have scar tissue in them. So let's say you got a regenerative medicine clinic, or you work with a regenerative medicine doc. I know a lot of docs that have basically gone to the one and done, all right? So you put that stem cell in there, how are you going to regenerate, break up the scar tissue in the ligaments? How are we going to do it, right? So that's one of the key factors, and that's why the neon track is so powerful in what we do. Okay, have to replace the pump that's been missing because number one, extension goes away almost immediately. Full extension, the screw home mechanism, is such an important event. Screw home, it is absolutely critical for proper lubrication of the knee. All right, as you go through mid stance and into toe off, the gastroc fires, the hamstrings fire, and you go into full extension. When you start to go into full extension, the popliteus fires and locks it all the way in place because the medial condyle is anterior compared to the lateral condyle because of the way it moves, right? And so the popliteus fires. That popliteus, make sure I have the right color here, okay? Runs like this, okay? It fires and pulls that knee all back, right? Guess what? This guy is he's about this long because he's in constant state. Constantly firing. That's why if you palpate the posterior knee, just like I did on Andy, he lit up, right? The popliteus is firing like crazy. Now, we took a look at Andy. Andy had 5 out of 5 motor strength. Now, if I challenged him into pain, past his motor strength, he broke away, went into a 3. That was pain related. So he didn't have a neurological deficit. Deep tendon, the patellar reflex was in good shape. He didn't have, a chronic problem. He's got an acute problem, right? So that's part of the reason why I felt so safe about putting him on here. I've always been very, very conservative in acute patients, okay? But if they're stable, you don't have any ligament laxity, things of that nature, you can go on for it. So now, that is why the neon track is so very powerful, okay? You don't have to, highly recommended that you rehab that interstitial scarring, all right? Because the whole concept is we want to unfold those ligaments, restore that ligament. Why? Because we need to increase that joint space, right? That is absolutely critical. You increase that joint space. Once you increase that joint space, you can restore the pumping mechanism and actually turn the blood supply back onto that meniscus, right? And as you pump, now that pump allows us to bring in fresh synovial fluid, what kicks in your lymphatic system, right? So fresh synovial fluid, lymphatics, all start to drive. So that milking action that the neon track creates for us, and it being specific to the knee and being able to put you in full extension is absolutely critical. So like with Andy, he had a lot of flexion issues, right? So if he couldn't go into full extension, I would have taken the pad off, right? So he could go and be in flexion. And then I'm going to move him to where I can actually put him in full extension. That's why this pad is movable. Okay. So those are some of the key questions, key factors. You need to unfold the ligament. So one of the things that I saw when I was in private practice, especially with our regenerative medicine, about 1 in 10 of our knee patients would come in. So our protocol was we do the injection. They come back in a week later. They get cleared from a medical standpoint. Make sure they don't have any infection. All right. Then they do once a week for 8 weeks on neon track, myofascial release, trigenics, spinal adjustment if it's appropriate, and then they would do active care in the clinic once a week. So basically, we would reiterate what they were doing at home care, and then every week they would get a new challenge. Okay. So when they came back for their first round of physical medicine with the neon track, about 1 in 10, it was usually our more severely degenerated patients, would come in with a cane, walking like this. Okay, and they were mad. They were pissed off because they were hurting way worse. And we're telling them, hey, this is going to drop your pain down. And the typical story was this: I felt great for the first 3 days, it knocked out all my pain. I was able to go do all the things I wanted to do. And then the 3rd day came around, I could barely get out of bed, or I could barely walk, so on and so forth. That's because that stem cell was starting to try to pump up that joint. Well, we had all that scar tissue in place, it wasn't able to, right? Typically with those patients, the first or second Neon Trac session, all that pain was gone. And they were back to the races, right? It was just odd. They didn't ever use the cane again, never came back for anything else, okay? So contraindications, active bacterial, viral, or fungal infections in bony joints. Gout is a big one. Active gout, if it's in remission, it's no big deal. Any of your autoimmune, you want to be careful that they're actively into that. Let's talk about diabetes. If somebody's diabetes is completely out of control, you are not going to get them better, okay? So the standard protocols for Neon Trac, JLT, Neon Trac protocol, 3 times a week for 8 weeks. I can't write. So that's 24 visits, okay? If they were doing a regenerative medicine protocol, they did once a week for 8 weeks, okay, for 8 visits. We did not need to put nearly as much mechanical input in, all right? Now it's just for the knee. Whatever else they needed. Very rarely, very, very rarely did I put somebody into a Neon Trac protocol that they weren't on the back on track as well, because the nerve roots, L4, 5, S1. So L3, 4, 5 are the main, the main functioners, neurological inputs for the knee, okay?
Yep.
So if somebody had a knee problem, immediately I'm taking a look at their low back. Okay, standard protocol for a knee patient. They come in, tell me, oh, my knee's been killing me for 85 years, right? Okay, great. Do a complete history. Now we're going to do orthopedic, and I'm going to look at it from head to toe. Okay, I might start off with their knee because that's where they're screaming. Make sure they don't have just absolute laxity in the knee, but I'm going to look up the neurokinetic chain. I'm going to look from the toe all the way to the brain, because I want to see where the nightmare is. Is it neck? Is it mid back? Is it low back? 90+% of the time it was low back. All right, L3, 4, 5, S1 was typically in trouble. Then I would shoot x-rays, right? If they were a chiropractic candidate at all, they're going to get 2 view neck, 1 view thoracic, 2 view lumbar spine, bilateral AP knees. Whatever knee they have joint space loss, they're going to lateral in that knee. Okay, I don't care if they brought in an MRI from 2 days ago. That's going to be my protocol, right? Because if I fix your knee, but I don't fix this, what's the point? If I can't turn that knee back on neurologically, I'm not doing my job, right? So we had patients that were 3 times a week on the back on track. They came in, did once a week on the knee on track because we did a joint, stem cell joint injection or a PRP or whatever it was, and we moved on, okay? Now, I know I talk about a lot about regenerative medicine in conjunction with the Neon Trac. It's because I have a ton of experience with it, but the Neon Trac does fantastic things without having to do regenerative medicine. You don't have to have the Neon Trac to do regenerative medicine. You can do regenerative medicine without the Neon Trac. I don't recommend it, but you don't have to be a regenerative medicine clinic in order to reap the benefits for your patients with the Neon Trac. It's absolutely a fantastic system as a standalone system. And if you've got back pain patients in your clinic, you've got knee patients. Anybody have any questions? Questions? Where are we at? What time? Sorry. No big deal. Oh, I got to watch this. Any specific question, guys? Man, we got quiet people this day. My first Neon Trac was. So let's talk about a couple other things. Tomorrow, I'm actually going to be doing a webinar specifically on sales, okay? I'm going to be looking at the emotion. I'm going to want to show you how to find the emotional connector or the life effect that actually get patients to move forward on your recommendations, okay? So I'm going to run through my initial history evaluation, all right? Give you some points and tips on where you need to go in order to get that emotional connector or life effect so that you can actually get them moving forward, okay? And then I'm going to give you some other ideas. Yep, we're going to be sending out a replay, Dr. Morgan, absolutely. And so tomorrow I'll be going over the sales aspect of the Neon Trac, okay? how you actually explain the knee on track in the report of findings in that sales process, okay, on the back on track, right, and on the total brain and body O2. Now, I've talked a lot about the knee on track today, but I want to talk, and I talked a little bit about the back on track. I want to talk about the total brain and body O2 because oxygen is the foundation for any regenerative process in the human body. And as a chiropractor, that's what you do. You stimulate the body into regenerative repair. There is no tissue. There is no tissue that oxygen, let me say, there is no healthy tissue in the human body that oxygen is not utilized by. There's no healthy tissue in the human body that does not utilize oxygen, O2, right? So if you got somebody with a bad knee and you're trying to get it to regenerate through chiropractic adjustment, myofascial release, trigenics with the knee on track, take a really close look at total brain body O2 because it actually helps the body stimulate regeneration on a cellular level, right? Because if they're not oxygenating their tissues, you know, you may have to adjust them 500 times, period. And they may never get better, okay? I'm of the mindset, if I can adjust you 12 times and get you better where it took me 100 times before, I'm gonna do it all day long. That's one of the things that total brain body can do for you, all right? So,
Dr. Ellen, did you review this whiteboard with your new patients?
Would I? Yeah, you could do that. I used x-rays, okay? And so that's a great question because that's one of the things that you do in the sales process in your report of findings, okay? So when I do this, and the reason why I do this because this is doctor speak, okay? I'm talking to you on a doctor level. You talk to a patient like that, then you're gonna lose them, all right? So basically what you need is, this is normal, okay? And you could do it like this, it's fine, but it's much more powerful when you have their x-ray, okay? Now their x-ray is not gonna be normal. If it is, you may not be doing this treatment protocol on them. So you have a normal knee x-ray, all right? You put that knee x-ray out. This is normal, this is what I wanna see. See this space here and here and here and here? That's what it should look like, okay? When that's like that, I go look for their life effect or the motion of nectar. When that knee looks like that for Andy, that means you can play soccer as much as you want every single day. Now that x-ray stays up, or if you don't have that capability, then what you do is you put their x-ray up. And you let it sit there and they look at it and you go, this is you. And you see that space from there to there? You see how that's different? Yeah, that's a problem. We got to fix that, okay? And that's it, okay? It's not everything I just did, okay? Right? I mean, it's like, this is good, that's bad. We got to make this look like that and work like that as much as we can. All right? I mean, literally, I've had 30-second x-ray explanations and that's it. All right? Because we geek out on x-rays, guys. Okay, I geek out on stuff like this. That's me. I love this stuff. But you start throwing this at a patient and they will glaze over and that's it, right? So basically, this is what's good. You're bad. I got to make this look like that as much as I can and make it work like this as much as I can. There's no guarantee on that, by the way, but that's what I've got to do. Good enough? And then you start talking about how long that takes, why it takes a full year for that entire recovery process to occur, why it's going to take 3 times a week over the next 8 weeks to make that happen. And then you go into why, what you're going to do in that treatment. Okay, so then you start talking about, I got to remove the neurological interference. I'm going to do that with chiropractic adjustment to remove the subluxation. We're going to do myofascial release because you've got scar tissue in here. You go through that whole mechanism. We're going to open up, plump up this joint space with the knee on track so that we can start getting fluid back in there, get that knee to move into full extension so you can walk without a cane. Because if we don't get you rid of that cane, the next thing you're going to go to a walker, then you're going to end up in a wheelchair, and then you're going to end up with a knee replacement, and then you may never get up and walk again, all right?
Question.
Mm-hmm.
What was the average cost of the 24 times for the knee on track, and what else did you do with it for a non-regenerative?
Okay. So average cost. So now I was all cash clinic. In the last clinic I was an associate in. Our standard knee. So we had a patient that came in with a knee right? And so a knee, they also had some degenerative process in the low back. So that program was if they prepaid, it was $39.95, okay? And that was for 24 visits. Now, if they split up the payments, that may be $46.25, okay? And that's with payments, right? So if they didn't want to take the biggest advantage of $39.95, I may have them go into a payment. That may be care credit, whatever it may be, okay? But it takes a lot more time and effort for my staff to be able to collect that, and I'm not getting it right now. You pay for it all at one time. That 24 visits means you're going to get a full spine adjustment, okay? You're going to get back on track, knee on track. That's 24 visits, okay? They probably get 8 visits of 3LT, cold laser, okay? And then they're going to get 16 of trigenics or myofascial release, all right? And then they're going to get a home care plan, and then they're going to get 8 visits of therapeutic exercise, all right? That's what they got. And there's 3 re-exams in there, because every 8 visits, I'm going to do a re-exam. Oh, so that gets them $4,000 on a pre. All right, that's a standard low back knee patient that needs cold laser because they got a lot of pain. They're going to need active care, home care. Yeah, back on track, knee on track. That's pretty much full package. All cash knee. Now now I guess there's how much should I charge? What we charged was per visit. Now that's not with the discount, but per visit was $55 per knee. Okay. If it was 2 knees at the same time, I gave them a 50% off. It was $82.50. 5 to 6 minute protocol. 10 to 12 knees an hour. Okay. We're doing both knees, $82.50. That's if they pay for it per visit. It comes out to be in a prepay. I think we were getting 43 a visit in a prepay, and this was like 69, something like that. About a 30% total discount. Further questions? That's it. Okay. So yeah, I'll go into that a little bit more tomorrow on the sales process. Understand, guys, that there's the clinical side of it, okay? So the clinical mastery is what gives you the confidence to be able to go in and know what you need to do for a patient, make recommendations. But it's really your job to get into sales and close them into care so that they activate, all right? I know a lot of docs don't like sales, but that's just the way it is, okay? So we're going to do tomorrow, it's going to be Thursday at 1 p.m., same time, okay? And guys, let us know if there's a better time. I know everybody here can't do it, right? But 1 o'clock, I'm Central Standard Time, so I'm trying to get West Coast and East Coast and Mountain Time all together. If there's a different time, like Monday, I did a 6:30 p.m. with Dr. Borrello. We had lots of docs on there. So I can move my schedule around. I'm not handcuffed to a patient schedule. So if I need to do something at 3 o'clock in the morning, I'm not doing 3 o'clock in the morning. 3 o'clock in the afternoon, or we do like 9 o'clock in the morning, 10, 11, something like that. Maybe we do an East Coast and a West Coast presentation. Just let us know. All right. Okay. Thanks, guys. I appreciate it. If you have any questions, concerns, if you love what we did today, give us a testimonial, guys. It helps us help so many more other doctors. Send us an email, a text, Facebook drop, whatever it may be. Give us a testimonial. We love helping you. So I need to know what kind of content that you're looking for. Okay. If you like the live patient demonstration, fantastic. If you want to see more setup, how to use the actual screen, what do you want us to put on the online resource center for as far as training? We had a doc that was telling us that there's nothing that shows us where to put the cutoff switch on the knee on track, and he is absolutely correct. Right? And we had another doc asking us, why does the foot pad slip the wrong way? There's a very specific reason. So let us know. I'm happy to put all the content out there that we need to put out there, and because we're really here to help you. You invested in us, we're going to invest in you so we can make this happen. Okay, guys? Don't forget, September 27th, 28th, Secrets to $1 Million Practice. Dr. Andy Barlow, Dr. Tony DeRamus. I just talked to Dr. Nelson Batanzi yesterday. They're all going to be with us. We got several other speakers. Plasma Solutions is going to most likely be there to talk about regenerative medicine and PRP specific to neuropathy and what we're doing with that. Exosomes, stem cells. It's going to be action-packed. On top of that, we're going to be giving away a Back on Track and a Knee on Track. We're looking for sponsors to help us give away cash prizes up to $5,000. So if you know anybody, let them know about us. We're shooting to have over 100 docs here. And if you bring a doc or help bring a doc who doesn't have our equipment, that gets you an extra ticket into the drawings to either win the Back on Track, Knee on Track. Okay, guys? We're going to really push to get our neck on track out between now and then. We've got our new repackage on the total brain and body. We got so much stuff. So get your tickets as soon as possible, because we're going to have a mastermind dinners for those first 10 ticket buyers, so we can sit down with the docs and you get to have some more one-on-one time, okay? September 27th, 28th, here at our world headquarters in Conroe, Texas, guys. All right, keep saving lives and keep doing what you're doing. We appreciate you.